Hello, everyone. It is an honor to be here today and present to you all over the world one of my cases. Some of my cases. It's actually my very first time to be presenting online, live. So I'm kind of a little nervous today. Hopefully I can deliver a good presentation today. So today I'm going to talk about minimally invasive implant therapy. So we all know that every procedure, like surgical procedure, has to have some of the post-operative morbidity. And we know from experience that as we minimize the opening of the surgical site, there will be less surgical complications following the surgery. So my idea today is, I want to talk about what the minimally invasive implant surgery is. So how we can do it, and of course it'll benefit the patient, and yeah, the less painful the surgery is, the happier your patient will be, and your practice, of course, will be more successful with happier patients. So yeah, first I'm going to talk about what minimally invasive implant surgery is, and I just put immediate implant placement because I'll explain later, but so basically the most minimally invasive implant surgery, how I think, is basically immediate implant placement. So I'm going to talk about that. I just put minimally invasive, also connective tissue graft, because I'm going to talk about some of the anterior cases during my presentation. So I just took this video on YouTube. Oh, I'm sorry. I'm gonna go back. Yeah, so this video explains about just conventional implant therapy, okay? So what you do first, when your patient will need an implant, you're going to first extract the tooth and then wait for maybe 3 months, conventionally speaking. And then you're going to go to the site, open it up, place the implant, suture the site. When it's a 2-stage surgery, you'll just embed your implant in the flap, wait for maybe another 3 months. You're going to go back for a re-entry or like a second operation. Take the healing abutment, replace the cover screw with the healing abutment, suture it up again, and then the patient has to come back for another stitch removement. So it takes a lot of appointment and, at least 3 times surgery, including the extraction. So I would say whenever your patient needs an implant, the first step of the surgery will be extraction, basically. So here I just made a little comparison between immediate implant placement and delayed implant placement, or like conventional implant placement. I'm just going to move a little away from the center. Yeah, so let's imagine a scenario where you do a very conventional implant placement, okay? So first you extract the tooth, take out the tooth, maybe wait, place the implant, second operation. That needs like at least 3 surgical appointments. How about in case where you just place the immediate implant? Then your patient will just have 1 appointment and your implant is already there. Unless you cover up the whole flap on top of the implant, the patient wouldn't need any more appointment. So 1 surgery, 1 appointment, your patient is done. So let's just imagine the least invasive implant surgery, like how it can be achieved. So just like I said before, immediate implant placement and your patient is done. Of course, if you don't raise the flap, if it's a flapless immediate implant placement, it'll be, of course, less invasive. And if you don't even do any sutures, that'll be like, the most untouched surgical site ever you can imagine. So how we do that? I'm just gonna go over a little bit of literature stuff. So of course, if you were to place your immediate implant, you gotta have the primary stability, and you need to have your buccal bone. If otherwise, you might have to think of a way where you can achieve that get back the lost buccal bone. Maybe you have to think about grafting and stuff. And yeah, also you would do a socket grafting and socket closure. How would you close this open socket, extracted socket? You have to think about that. So, so when you look at the literature about how the survival rate will be on a fresh extraction socket or like healed ridge, the literature tells us that the survival rates is similar. Of course, you need to have primary stability. You can't really overemphasize on having primary stability, so there's no question about that. Buccal bone is important. And we also know that immediate implant placement does not prevent the loss of buccal bone after extraction. So you also have to keep that in mind. If you have a very thin, let's say a very thin buccal bone, and you don't really have much of a space towards, on the buccal side of your implant, you have to be really careful, because you will have some of the loss of the buccal bone, right? And there's a little bit of controversy about socket grafting, whether you should do it or not. But most of the literature supports that grafting is recommended because it'll improve the level of marginal bone to implant contact. Socket closure. So, okay, so first, let's just briefly talk about the flapless surgery. So if you don't open up the flap when doing the immediate implant placement, that'll really prevent or like reduce the bone loss in recession. So it's a better scenario. You just keep the flap there and just place the implant, graft the socket, and that's it. One of the articles from Tarnow supports the fact that immediate provisionalization of the immediately placed implant will enhance soft tissue contours. So what that means is that if you don't suture or raise a flap and try to close that gap or the socket, the empty socket, open socket, it's actually better just to put like a provisional crown or whatever stuff to close the socket without suture. So you can sum up the ideas that I just talked about like this. So just like I said, immediate placement, flapless, no suture, and I added one more sentence at the last, which is socket covering with composite. So I'm going to explain to you about the last thing that I've just wrote. I call it composite cap technique. So this is the idea. So all these cases you see on the photo is immediate implant placement with the composite cap technique. So what composite cap technique is basically you engage a wide healing abutment that can that really fits into the socket, and if some of there's like more space than the healing abutment, you'll add flowable composite on the healing abutment. So the idea of doing this is this. So we just talked about the article by Tarnow that when you place immediate provisional restorations on fresh extraction socket, it'll enhance or prevent the bone loss, or it'll just keep the soft tissue profile, as you can see right here with anterior cases. If you do this, it'll really do the job without any suture, you know? It'll just keep the blood clot underneath the provisional crown, and of course the grafting material and so forth. But this also comes with a risk, you know. You're just placing immediate implant, and the socket is just basically empty. Well, it's filled up with grafting material, but you know, it's just there without any really solid support from the nature bone, right? So if you want to reduce or minimize the risk, what you can do is you can just shave off or cut off the crown portion and make a custom healing abutment. So this will also do a really good job. The only downside of this is that it'll take time. You know, you have to fabricate or reline cold cure acrylic around the custom, the how do you call it? The custom healing abutment. I think it's a stock. Yeah, you have like a stock abutment, and then you add your acrylic or composite, whatever it is, and then you have to shape it and polish it, and it takes a lot of time. But what if you just do this, right? Let me just, yeah. So it's nothing, just, you know, titanium healing abutment and a little bit of composite. 30 seconds, you're done. So it's really easy, takes minimal time, saves you from a lot of work and trouble. I've been doing this for many years so far, about 5 years now. I do most of my cases, immediate cases, like this way, and surprisingly there's almost not much of a complication, let's say inflammation of the grafting material or whatever it is. It is a very predictable procedure. So I would like to present some of my cases here today with the composite cap techniques. So all of these I do because it is basically the minimally invasive approach. Your patient is happy. You know, they really don't really complain that much of post-operative pain or swelling or whatever. Okay, so if you look at the CT scan of both number 16 and 36, both of these two have periradicular pathosis after having previous root canals and stuff. So these teeth were deemed unrestorable. So we just decided to take them out and place implants. Notice number 16, the position of number 16 is a little bit shifted towards the palatal, but yeah, we just went ahead, placed the implant, grafted the site, placed the healing abutment, composite. So this was done maybe less than 20 minutes or so, and the patient was done. So just like I said, taking out the tooth, removing the infectious tissues, granulation tissue. You have to really clean up well. But basically, you're just done in day one. and the patient doesn't have to come back for stitch removal or second operation whatsoever. It's just done in 20 minutes and your patient is ready for the prosthesis after healing. So this is done for number 36. Notice there's a little bit of very small, like a dimple-ish dot here on the ridge. The septum. So how I do this is, so because it is not easy to place your implant at the very center of the remaining septum, how I do is I use high-speed surgical burr to do my first osteotomy. So with this, you can always change the direction or position of your osteotomy. You're using this because you have to take the tooth out anyway. So your high speed is already prepared. So I would use this to dissect the root. That can give me a little ease to take out the root canal treated tooth. So this is really, really helpful to hold your position, your osteotomy, without really wobbling. Yeah, so it's really a good way to do it. So this is after the implant placement. Yeah, this is after the prosthesis went in. So notice there was a little bit of shift of the position of number 16. I ended up placing the implant a little bit towards the palatal because of the given position, but I just made my final crown according to the arch, following the arch. And here's number 36. Notice how well the soft tissue was just preserved. Of course there's a little bit of loss of the volume on the buccal, but this is actually very minimal. You can really see how similar it is, how harmonious your pharyngeal contour is compared to where we started, like here. Okay. So this is the final panel and post-operative 9-month periapical radiograph shows very nice healing, and look how well positioned the implant is with the help of the surgical burr. Okay. Another case, similar case. So a patient came in with the infection on number 26. The tooth looked like this. There's a very deep caries, almost got into the root. So the prognosis didn't seem to be good. So we just decided to take it out. You can see the fresh extracted socket here. So here also I used the surgical burr with high speed. Notice my initial osteotomy right here. So as you can see, I did a little bit of, so the position of the initial osteotomy is a little bit towards the buccal. When you see this, you imagine a line that dissects the central fossa. It's a little bit towards the buccal, but I did this because I know that with the following osteotomy, my drill will shift towards the palatal because I have a really big empty space of the palatal root. So yeah, so look, if you look at here, I also did a little bit of crestal elevation of the sinus with the SLI kit. Crestal gel. from Neobiotech. So you can see here, this is after the osteotomy of to elevate the sinus, and it just falls right in the center after a couple of osteotomy. Okay, and then I place the implant dead center, and then I graft the site. Another same technique, composite cap technique, and this is how it looked immediately after the implant placement. You can see the bone feeling after 1 month, and went ahead and finalized the case. And this is the final panel. Looks pretty good. So I just show you 2 cases of posterior immediate case, implant placement case, and then we're just going to discuss a little bit about the anterior situation here. Okay, so the patient, one of my patients comes in. Her chief complaint was that she has something going on in the middle of her upper front teeth, and she was very good-looking young lady in her late 20s. So aesthetic was a big concern, and also we had to deal with the periapical or periradicular pathosis here. So here you can see number 11 and 12 both has radiolucency around the apex. If you see the CT scan of number 21, the patient already has a very sizable cast posting core, and her buccal plate is missing with the infection. So the prognosis of number 21 seemed very questionable, and we ended up decided to take it out and place the implant eventually. So number 11, number 12, I did root canal, some parapost with composite core, and for number 21, what I did in this case was I did socket shield technique. So socket shield technique is described very well in this article by Glickman, and this shows you the procedure of the socket shield technique. So what you basically do is before extracting the tooth, what you do is you just remove the crown portion of the tooth, and then you kind of bisect the root vertically and leave the buccal portion of the root on the buccal plate, and then place the implant, graft the site, and you're done. So the whole idea of this is to preserve the buccal bone, because whenever your root is attached in the bone, or your root is inside the bone, your bone tends to just stay, right? It does not resorb. So yeah, this is described in the article. So a little bit of literature is first described by Herzler, but most of, I think Glickman did a very good job on describing the technique, and he did a lot of cases with follow-up, and he reported 96.1% survival rate. So this is a systemic review article comparing the socket shield technique done on animal. So this is histological study done on dogs, and this is actually a clinical study. So if you compare these two, unlike most of the articles done on animals, because like there's like a joke when you do whatever on the dogs, everything's gonna work. But if you start doing it on human, then nothing works, right? So, but this case is quite the opposite. If you see this here, the percentage of failure of osseointegration on animal with the socket shield technique is actually very high, 27%. So if you fail, let's say 1 out of 3, you're not going to do that, right? So it doesn't work on animals. But however, if you see on the right side, clinically, you have not that small amount of complication, which is basically a shield exposure. So what shield exposure means, some part of your root may be exposed on after time. So in that case, so Glickman, he described on his article, whenever that happens, you have to have like a backup plan. So for example, you might just remove the remaining buccal root and then replace the empty space with GBR, or you have to consider, let's say, connective tissue graft to cover that exposed root. So you've got to have some of the backup plans. In 15% of socket shield technique cases, but even though you might have, so I've done many cases with socket shield technique. I did have some of the exposures. What I did was, some of the cases I just shaved down, because like mostly the coronal portion of the root can be exposed. So some of the times I just shave it with high-speed burn, and then your soft tissue will cover up again. Or in some of the cases I did have to take out the root, but I think it was maybe one case. So very few. So yeah, here is the photo of the surgical procedure. So notice how I place my implant on the palatal side. I do have some of the gaps for the grafting material. I have like 1.5 millimeter thickness of the root, the buccal portion of the root, and then I placed my healing abutment with the composite cap technique I just described. So I prepared the PMMA provisional right after, and this is the PMA restoration. Notice there's a little bit of recession on here. So what I did was I did a little bit of adjustment on here because I thought the temporary crown was a little too thick. So this is on the day of making impression, and this is the final. So nicely healed, and this shows the final periapical. This is the final CT scan. I do have a little bit of thin portion at the apex of here, but I did gain quite a bit of bone around the implant, so it's not bad at all. I mean, I didn't gain, but I could preserve what I had from the beginning, right? You can see these two. So this here, what you see on this side is actually the buccal portion of the root, right? So before and after, quite successful implant therapy, right? So here's another case with the same technique. Patient comes in, very nice looking young lady. Again, so she was really, really concerned about like losing her front teeth, because she came in because her front teeth were loose. So you can see very severe secondary caries underneath the prosthesis. So yeah, CT scan shows you almost no buccal bone, very, very thin. So again, we decided to go ahead and do the socket shield technique, and this is the video of how I did. Okay, so first you remove, of course, the caries and everything, and you start shaving the buccal portion of your root until you meet the crestal bone level, right? And what I do afterwards is that I follow the gutta percha with the high speed. It goes in really, really passively because it's just basically a gutta percha. And then if you hit, almost hit the apex, then you just go mesiodistally. But you also have to be really, really careful not to cut too much of, alveolar bone. And then you take out the palatal portion of the root with periotome. And then if you want to be more conservative, if you want to be more careful with shaving down the root on the buccal part until the coronal level, crestal level, you can also use whatever instrument you have. In this case, I used Gracie Curate, and I do my osteotomy and place the implant. Okay, so this shows you how I extracted the palatal portion of the root. This is after the extraction. You can see there's a nice thin buccal portion of the root and nice space for the grafting material in your implant. And then also the socket, composite cap technique was used. Provisional was done immediately. This is after 2 months. Healing was uneventful. We just went ahead, switched like the bridge type of provisional to a single provisional on the implant. I did lose some of the papilla post-operatively here, but you can see after a couple months, the papilla will grow back. So you don't really have to worry too much. Unless you lost maybe quite a bit of alveolar bone from adjacent teeth. So this shows you a very nice emergence profile. I just went ahead with the final restoration. Yeah, this is the final restoration before and after. So yeah, I mean, it's not bad at all, right? So the most advantage, I would say, of this technique is that your patient doesn't have to go through major surgeries. Imagine a situation where you take out the tooth and wait for 3 months. Your patient will go through dramatic bone loss in the buccal area, and then you have to open the flap, do massive GBR, suture, releasing incision, scars, all that. And most importantly, the patient's life quality will just not be good, with that kind of big surgeries. You also have to be careful about the graft because you don't want to put any pressure on the graft. So maybe you have to be very careful about the provisionals as well. So, I mean, adding all that, your patient's life quality will not be as good, unlike, you do the procedure like this. Okay, I'm just going to skip a couple slides because I think there will be my last case. Okay, so yeah, this is going to be our last case today. So what I did for this is that I did connective tissue graft with immediate placement and all the same technique. So the patient comes in, she says her front tooth is mobile here, and she has swelling and is mobile. As you can see, number 11 crown is already bigger, and the free gingival margin is already up here. So imagine a situation where you take it out, it'll go through more recession, and you're going to end up having really, really long crown, and it's very it just stands out and it doesn't look nice. So she already knew about this, and she said she wanted her front teeth to look the same, and it's a challenge. not gonna lie. So after taking the CT scan, I noticed there's external resorption on the root here. So I had no choice but to take it out. In this case, I didn't really have a luxury to leave any buccal portion of the root because the root has already been resorbed, right? So this is how I took out the tooth with the periodontal very carefully. And then, yeah, place the implant, graft this aside. So I did connective tissue graft here on the same day. So this doesn't have other grafted, grafting material photos, but yeah, this is how it looked immediately after the surgery. I'm sorry, this is the very next day when the patient came in for dressing. Yeah, also you can see this is, I think this is like a 1 month post-op, and you can see the composite still there, nicely healed, and look how well preserved the contour of the ridge is. So your graft, your connective tissue graft will go through also like resorption. So what you want to do is you want to graft more than you actually need because you know that it'll go through resorption. So, but after all, it was healed very nicely. Here's a little bit of how I do with my provisionals. What I use is I use PMMA, and how I do is I make a little dimple. So the idea is to, so because what I believe is that when you use a culture acrylic powder and liquid, it's very porous, and your tissue doesn't like it, right? So instead, I would like to use composite resin. So what I do is I use a dual cure composite resin instead of cold cure acrylic. So I know that it's not going to bond on the PMMA. I use like mechanical retention. So that's why I make a lot of dimples and sandblast it, do my adhesive, and then reline it. Maybe give a little color with darker composite, and then polish it, and then deliver it to the patient. So this is actually how it looks like on the PA. Notice there's like a dimple-ish circle stuff going on, and yeah, very nice emergence profile can be created while using this technique. Yeah, so as you can see here, I actually have more than I need the soft tissue, the height-wise, but you know, it's always better to have more tissue than less, because it's easy to just make your tissue go higher up apically than bringing it down coronally, right? Everybody knows that. So it's just simple. You make thicker buccal volume, and then your tissue will go up. And I did a little bit of that. Here you can notice I prepared for a laminate veneer on number 21, just because she wanted the even size of those two centrals. So this is a provisional. So what I tried to do was I actually added a little more on the buccal here, and you can notice the gingival margin is almost at the same level now. And also the widths of number 21 and 11 almost look the same now. So this is the final with the implant and the laminate veneer on 21. So compared to how it started, we actually gained more soft tissue on number 11, sorry, by using connective tissue graft. So yeah, very nicely looking restoration, and this is how it showed on the final panel. Yeah, so to conclude my presentation today, I'm sorry. I'm sorry. A little bit of different. Oh. I'm gonna fix it really quick. Yeah, sorry for the little confusion. Yeah, so minimal invasive implant surgery allows fast recovery and minimal patient discomfort, which will make your patient happier, and then it's good for your business, right? Also, composite cap technique seems to preserve the contour of the extraction socket in a rather convenient way. Yeah, so this is it. This is all about how much I prepared for today's presentation. I know all of us today are going through a very hard time because of the COVID-19 virus and stuff. So I hope you all of you to stay healthy and safe with your families and friends. So thank you very much.